I think so, yeah, you hear me, yeah. Okay, good. There isn't something for the slide to be moved? Not here. Okay. Only with this. Right. When we discuss a myopathy, we need always to differentiate in between a myopathy and neuropathy and myoneural junction disease. So you can go into that. This is kind of a neurology to see where the reflexes are there and where are not, if there is a sensory involvement, if there is atrophy or not. If there is fatigue, obviously you'll have fatigue in all kind of types of disease. And there are some examples there. So you can go into that and how I move it. Oh, right. Again, this is just for you to remind the muscle structure and just to realize how complex the muscle fiber is and how many proteins are there in order to help our muscles to function, to contract and to relax. And you already studied in this problem a bit of the structure of the muscle and the contraction, which are the proteins, how you produce energy and so on. So this slide is just for you to remind how complex the situation is and to understand that all these amazing proteins, and you have here dystrophin, you see a big, long lane. Dystrophin is one of the biggest protein in our muscles. All of them are the product of genes. So if you have mutations in the genes codifying for these proteins, it's leading to have a lot of muscular problems. What is happening? Right. So what is the muscular dystrophy? With the term of muscular dystrophy, we combine all genetically determined disorders who are affecting the muscles. They generally leading to progressive degeneration of the muscles with increased disability and obviously reduced independence. And they have a very variable presentation. That's very challenging in genetics because the symptoms the patient are facing are muscular weakness in different parts of the body. But then knowing how complex the muscular fiber is and the junction, then you know that can be plenty of genes leading to the same symptoms. And also, unfortunately, they don't have cure, or at least some years back, like 3-4 years back, we thought that they have no cures, but there are now a lot of research done into that, and new approach and new therapies already started to appear. We know about 30 variations of muscular disorders, and the reason of variation is related with the age of the symptoms. So some of them are starting early in childhood, some of them can start of the teenager time, or some of them late in adulthood. They can affect different parts of our body, different groups and regions of the muscles. All of them, they lead to disability, but not all of them lead to the severe disability very fast. Some of them are really affected life expectancy. I mean, in Duchenne, people are dying around the age of 20, 25. And some of them are affecting only males, and some of them can affect both genders. Now, as I explained what causes muscular dystrophy, obviously gene mutations affecting the proteins involved in the structures and functions of the muscles. And the inheritance, it's very variable, can be recessive, like it's Duchenne muscular dystrophy, can be dominant disorders, can be X-linked disorders, and sometimes it's not a particular type of inheritance. I mean, there is nobody in the family to link with. It's just a spontaneous mutation that it's happening. Now, the main symptoms vary from disorder to disorders. They lead to contracture, to pain, to inability to walk. If it's affecting the face, the facial muscle weakness, ptosis, solo impairments if it's the upper part, visual impairment, scoliosis if it's affecting the trunk, respiratory muscle weakness, dilated cardiomyopathy. Do not forget heart, it's a muscle, and leading also to cardiac arrhythmias. Many times, and I will explain you soon, some myopathies are manifesting as a cardiac disease. So how you do a diagnosis, you need to have some investigations of the symptoms. You have to do really a very in-depth anamnesis and to see the family history, to see if there's someone affected or not, which gender, which age, what symptoms, any tests have been done for them. You do blood test and you look for creatine kinase, because what is creatine kinase? It's a result of a destruction of the protein in the muscles. So if CK is high, it's giving you a clue that something is happening in the muscles. And you will see you have disorders when CK is having thousands, 10,000s, and others where it's just mildly increased. And then you need to make really a differential diagnosis. Electromyography, it's helping you to understand the capacity of the muscle to contract. Muscle biopsy, it's very, very useful because it will tell you immediately what kind of proteins are there and what not, but it is an invasive procedure. And nowadays, we just jump that and go directly to the genetic test. And if it's required, if the genetic test is not conclusive and we still need to have a validation, you can go back to do a muscular biopsy, but generally you go to the genetic test. And you might have symptom-specific tests, and this is referring to, for example, if you're ready from the clinical phenotype, you guess, okay, this looks like facioscapular humeral dystrophy, let's go test these genes because these are the ones associated with. If I feel that it's Duchenne, I can go directly to the dystrophy and I don't need to go in a wide panel of genes. So something like that, like a small example, you can go through it. So there are different kinds of myopathies. I said there are also acquired myopathies, can be infections, trauma, or whatever, viral infections. But we discussed today about the inherited one. They can be autosomal dominant, and we'll discuss about some. They can be X-linked. They can be autosomal recessive, also related with metabolic disorders can be. They can be, I mean, all of them are congenital, but some of them are, the term congenital here, it's referring to the fact that they are manifesting immediately after birth. They are very, very severe, and they manifest immediately after the birth. And there are also other kind of myopathies. I want you just to understand, you don't need to memorize this, but it's just to understand that the subject that we discuss, it's quite very broad. So we will focus on some, just to have an idea, and later on in clinical practice, if you find a patient who has signs of muscular weakness and some of the symptoms that I already described, depends in different parts of the body, to think, am I in front of a patient with a genetic myopathy? Do I need to investigate more? Do I need to send the patient to a specialist, a consultant? Do I need to ask for a genetic test? And which test to ask? So they are differentiated based on what kind of group muscles in the body are affecting. You see, Duchenne, it's affecting immediately the proximal near the girdle and the upper part of the body. Then Emery-Dreifuss, it's affecting the cuffs and the shoulders and the upper part of the arms. If it's a congenital muscular dystrophy, as I told you, it's very, very severe and will affect the entire body, and we'll see it immediately at birth. If it's limb girdle, will be only the girdles, right? The upper part and the lower part, quite frequent in this part of the world. If it's facioscapulohumeral, will affect the face and the scapula, the region that you study now in the problem. And if it's oculopharyngeal, will be just the face, nothing else. Again, this is just for you to understand, if you have a patient with symptoms, to think, what kind of myopathy this be? Is affecting the entire body? It's affecting only this region? Shall I go to think it might be Duchenne? It's a boy. It's affecting the patient, it's saying that has also sisters affected, so it's not X-linked, might be recessive autosomal, and so and so. Limbogirdle, this is the one quite frequent, 2 in 100,000 individuals, but these are dry statistics in the books. The incidence vary from different regions of the world. It's affecting males and females equally. The muscle weakness ranges from childhood to late adulthood. Generally, the diagnosis is made around the age of 20-25, but you can have patients who are diagnosed early or patients who are diagnosed later at the age of 40. The muscles involved first are the shoulder and the hips, and other affected area can be the heart, the diaphragm, and the spine. Can be mainly autosomal recessive, but sometimes there are also autosomal dominant. And what you look on the CK, that it's elevated. You can do electromyography and muscular biopsy, but it's less specific. So again, another criteria not to go invasive immediately. ECG, it's normal. And these are the clinical manifestations looking on the muscles that are affected. The prognosis vary, but generally they reach the wheelchair around the age of 30. I have patients who are in a wheelchair since the age of 25, others who reach the wheelchair at the age of 40. So it depends. You'll see there are different types of limbogirdle muscular dystrophy, plenty, and different genes, right? Again, you don't need to memorize that. This is heavy genetics. But for you to understand that some are dominant and some are recessive. And now if you look carefully, I put in brackets, or in red near, the protein affected. Going back to the first slide where we looked in deep on the structure of the muscles and then the muscular junction, right? In limbogirdle 2A you have calpain, and in 2B you have dysferlin. And in 1B you have laminin. So laminin, calpain, dysferlin, and fukutin and others, they are very, very different. So therefore, it's difficult to diagnose clinically a particular type. So if you have a patient, you cannot say this is type 2B, or this is type 2D, or this is type 2L, just looking to the patient on the investigations you do. So you need to look to the genes, and you need to look to all genes in the same time, because you don't know which gene is affected. Therefore, if you have a patient, it's very important to ask if there is positive family history, and if anybody else done a test, because if they done a test and the result is there, your patient has the same thing. If not, you need to go extensive to do a panel looking for the muscular dystrophies. Facioscapulohumeral, it's 4 in 100,000. It's affecting more males than females. We don't know exactly why. We'll see immediately. Muscle weakness around the age of 20. The face, the shoulders, other areas around, so the ears, the eyes, the heart, and the trunk. CK, it's very high elevated. If you do an EMG, it's not non-specific. The prognosis is mildly disease that can lead to minimal disability. Some patients can live quite a good life till the age of 45, 50, sometimes 60, others not. And the cause it's in a particular gene who is having a particular mutation. You have multiple repeats in the gene. Right? And here you have a difference, a slide presenting both to see how you can make the difference. So here you have limbogirdle muscular dystrophy, and here you have facioscapulohumeral dystrophy. These are quite easy to differentiate clinically. You just examine your patient and you know exactly what in front of which disease you are. Emery-Dreifuss, it's a bit rare. It's affecting only males. And the muscle weakness, it's early. You see, as I said, it's very variable, can be very early or can be late. The first muscles are the upper arms and the lower legs. They will tell you, no, I'm feeling difficulties on walking. Generally, it's a boy of the age of 5, 10 years old, and I cannot play football at school. I really feel weak. And if I need to carry my bag, it's very difficult. So it's upper and lower, right? And it's X-linked recessive. Sometimes can be autosomal dominant, but that's very rare. CK, it's mildly elevated, right? And it's very slow progressive, and they can survive till the late adult. There are a lot of supportive treatments, but very important in Emery-Dreifuss, it's the heart. So this is what you need to monitor. Oculopharyngeal, it's again the same frequency like Emery-Dreifuss. It's affecting also males and females. It's generally after the age of 40. You see later, right? The face it's affecting first, and the other regions are the throat. They will have swallowing difficulties. Now Duchenne. This is so important. It's a disease so much studied and quite frequent all over the world. 16 from 100,000 males, even much more. Only males because it's X-linked recessive. The muscle weakness is starting before the age of 5. Muscles involve upper arms and legs, and there are other areas involved. Dystrophin gene, it's one of the biggest genes, has 79 exons, and it's expressing not only in the muscles, in plenty other parts of the body, including the brain. So people with Duchenne muscular dystrophy, they are also having kind of mental disabilities. A lot of them are diagnosed wrong as being autistic. So keep in mind, if you have a boy of 4 who is clumsy, who is falling down, who is having difficulties of climbing stairs, and is already diagnosed by autism, do immediately a test for Duchenne. I had some patients like that, and they came to me as a geneticist because they thought that it's a genetic cause of autism, but actually was Duchenne. And as fast as you diagnose Duchenne nowadays, there are treatments who can really keep the patient on the floating line, and there are new treatments on the way, right? So dystrophin, it's a huge gene, and again, what it's doing in the fiber muscles. And there is a big complex of dystrophin-associated proteins, and according to where the mutation is in this big gene, you might have a fully Duchenne muscular dystrophy if you have big deletion. You have Becker muscular dystrophy if there are only some particular types of mutation in the gene, and somehow, because of the particular mutation, the DNA is still able to be read, and a protein is coming out, even if it's not fully and it's not fully functional. You will have a mild form of Duchenne called Becker muscular dystrophy. And then you might have, again, depends where the change is in the gene, you might have only dilated cardiomyopathy, nothing else. Later on, the muscular symptoms will come, but later. So X-linked recessive, 30% of people are having a new mutation. It's not inherited. It's not the mom carrier. It's just happening because it's a huge gene with high susceptibility to become mutated, right? Different kind of changes inside. Most mutation, deletions, and exons 46 and 51. And that's a depiction of the gene and different domains of the gene for your knowledge if you want to read more. And this is how the gene is looking. The red spots are the places where the gene is more susceptible to be breaked. So you see, can be anywhere. Of course, if the deletions are in the beginning of the gene, it will be severe Duchenne muscular dystrophy. If it's in the middle, the symptoms will not be very severe because still you will have some. If it's in the end, you'll have, again, different symptoms, depends how big the protein that can be synthesized is, and you might have just the heart and then some mental issues. Right? So what this will lead in Duchenne, because of the lack of the dystrophin, then will be a frequent cycle of degeneration and regeneration of the muscle fibers. And finally, all fiber muscles will be replaced with the fibrotic tissue, and it's irreparable. I mean, you cannot reverse the damage. It's there. The muscle is just fiber, and nothing can be done. Unfortunately, these people are reaching the wheelchair around the age of 10. Around the age of 18, 20, it's starting severe respiratory failure and the heart failure, because the heart will be severely affected, and they die around the age of 20, 25. Otherwise, a lot of them depends where the mutation is. They might have normal intelligence. It's a horrible disease. A lot of research is done into that. We already have some treatments. The disease can be caused by deletion and mutations. We have some treatment who are helping particular deletion to escape. If the deletion is here, there is a drug who is binding here, and it's helping the translation to be done, to have a protein. And there are some drugs, if there is a point mutation, the same that point mutation can be avoided, but only particular point mutation. And I put it here in the end of the slides. You'll see recently, I mean last week, FDA approved a treatment by CRISPR. You know what CRISPR is? Gene editing. When you go with the Caesar in the gene and you correct and go out, the Nobel Prize last year for genetics, Emmanuel Charpentier and Jennifer Duda from Berkeley, you know, read science, you are doctors, you have to read about, right? So they use CRISPR on the stem cells of a patient, but if the patient has a particular change in the exon 1, remember we still have 78. So it's a huge step further, right? And they already have a patient that is starting to improve, and it's enough only one injection, not more. I mean, one procedure. But they said the patient need to be monitored 15 years. But for us, it's amazing news. I put it in the end, right? I explained this already. CK, it's very high, 15,000, 13,000. Remember, I told you in others it's just very mild. And if it's a little boy, you are in front of Duchenne. Don't forget what I told you. If you have a boy with autism, test him for Duchenne. And this is the stepwise of the test. Of course, you go with a test who is looking more first with the most frequent genetic mechanism, that is deletion. This is called MLPA. And then if you don't find anything, you need to sequence the gene, because about 10% of the patients might have point mutation, for whom, as I told you, nowadays there is a treatment. So it's very important to pick up these patients. Right? We don't do biopsies, only it's absolutely necessary. We don't do biopsy. We just go for the genetic testing. Becker, it's mild. It's the same gene. But the problem is, this is the difference in between DMD and BMD. So in DMD, the mutation, the deletion or point mutation is leading to a stop codon, so nothing will be processed further. But in BMD, it's leading to a truncated dystrophin protein, right? So you are in an in-frame mutation, and here you are out of the frame. So because it's in-frame, then the symptoms will be mild. So therefore, genetic testing is very, very important, because the genetic testing will tell you where the defect is, and then the prognosis is different. But in Becker, what you need to be careful is the heart. So you have to monitor the heart, because cardiomyopathy might be presenting as the time of main feature, right? And these are, as I already told you, there are some therapies. This is the exon skipping one that I explained. There is for 51, for 45, and I think for 57. So there are 3 drugs for particular exons to jump. Okay, and this is the other one for the particular mutation, right? This is called ataluren, and the other one is called exondys, and beyondys. And this is ataluren. It's less important. For you, it's important to know that nowadays, in 2020, there are 3 therapies available for Duchenne. They can save lives for some patients. Identifying clinically who is the patient with a Duchenne, it's very, very important, because that patient might be suitable, eligible for one of these therapies. No matter if they are very expensive, they are helped all over the world by big charities, by governments, and something to enter into the therapy. And it's very, very important, all these disorders, to be clarified, certified genetically, because you can prevent another case to be born in the family. Nowadays, we do pre-implantation genetic diagnosis, and we can help these disorders, some of them lethal, to be sent to the next generation. So if it's X-linked, who will test immediately? The mom. If she's not carrier, thanks God, the probability that the sisters are carrier is less. But if she's carrier, the sisters of that boy can be a carrier, and they can have affected boys. So that's very, very important, right? And this is what I was just telling you. I put this slide, I think 2 years back, and when the research started into that, this is, you take a cell from a patient, you induce it, you take from the skin, fibroblast, you induce it to the pluripotent stem cell, this means IPS, induced pluripotent stem cells. Then you come with the gene editing, with the CRISPR, you modify, you correct, you grow the cell in particular environment, and then you put it back in the muscle in this context. This is cell therapy that I told you 2 weeks ago, FDA already gave approval to be used for the exon 1. This is, right? You have the links there to go and read, right? First in human CRISPR therapeutic to be administered in a patient with DMD. This is amazing. I don't know if you get it, but we are very, very excited. When I was a student like you, I never thought that something can be done for Duchenne, because it's such complex and such long, big gene with different changes inside. But look, it is. So in the years when you'll finish university and you'll become specialist consultants, for sure will be indeed a cure for Duchenne, hopefully for this 100,000 people all over the world and their families who are suffering terrible, right? So if I have a patient with a muscular weakness, what I need to do? Look carefully on the clinical, look for the history, draw the pedigree, run some simple biochemical testing looking for creatine kinase. If I can, for the electromyography, I don't go on the biopsy directly. I do a genetic test, but I need to think which genetic test I do. Now we have also big panels. We do also a whole exome if it's required. And then if I have a precise genetic diagnosis, I will have a final diagnosis, and then I can offer genetic counseling, and I know how to do the management on the long term, what I need to pay attention to, the heart, the spine, and other things, right? And how I can do the surveillance. Keep in mind that a lot of these disorders for whom we knew it from the past that there is no cure are having now a lot of hopes nowadays. There are treatment approved, and there are treatment on the way, and there is a lot of research and a lot of clinical trials done. So you never know who can benefit of that. If you do not have access to the information to send it to your patient, the patients will not know, because you are the authority. Even they read in the press, they will not understand what is that, right? Okay, so no cure, it's false now because new therapies are coming on the way. And there are plenty other things to be done, like you learn in your problem, like how you sustain the patient with septic arthritis, right? There are plenty of things, medication, you can do surgery. If it's affecting the swallowing, there are particular exercises into that. Heart need to be monitored. Education and health promotion is very, very important. And alternative therapies, they are welcome to come because, for example, diet is very important for this patient. Psychological support is very important. And having emotional support, again, it's very important. So I made this a marathon. Hope that was useful. And if you have questions, you have my email in the presentation and you can ask me.